Good afternoon and welcome to today's webinar, How Restrictive Pain Medication Policies May Reduce Access for Cancer Patients. I'm Kristen Santiago, Director of Strategic Initiatives for C-Change, and I will be the moderator for this webinar. The question and answer session will occur at the end of the webinar. Please submit your questions via the questions function. This webinar is being recorded and will be available on the cchangetogether.org website and emailed on Monday. We would like to thank Purdue Pharma, who generously provided an unrestricted educational grant to C-Change that helps to fund this webinar as part of our work to assure value in cancer care. The objectives of today's webinar are to educate participants about the unintended consequences of restrictive pain management policies at both the federal and state levels, and to share some resources and tools available for advocacy. We're going to begin our webinar with 2 polls to get a better understanding of who our audiences are today. And the first poll should launch. So do you perceive access to appropriate pain medications to be problematic? Please select if you don't feel it's problematic, if it's somewhat problematic, or if you definitely feel that this is problematic. And we'll give a few moments for people to enter their results. Okay. Thank you for those who have responded to the poll. The results show that approximately half feel it's somewhat problematic, 39% feel it's problematic, and 6% feel that this is not problematic. And now we're going to launch the second poll. This is similar to the first one, but a little different. Do you perceive access to pain care to be problematic? Not problematic, somewhat problematic, or problematic? Okay, and these results are a little bit similar. About 55% feel that this is somewhat problematic, and 40% that feel that it is problematic. So pain remains one of the most feared and burdensome symptoms for cancer patients and survivors. Although nearly all cancer pain can be relieved through appropriate management of symptoms, way too many people with cancer are suffering. Nearly 40% of 5-year cancer survivors report pain. 60 to 85% of people with advanced cancer report pain. And 26% of unscheduled hospital admissions are due to uncontrolled pain. Beyond discomfort, cancer-related pain can interfere with the ability of patients to adhere to recommended treatments and can devastate quality of life, affecting their work, appetite, sleep, and time with family and friends. So why are so many people suffering, and why is so much pain going untreated? Our 2 speakers today will begin to answer these questions by sharing with us some policies at both the federal and state levels that were implemented with the purpose of preventing misuse and abuse of prescription medications. Unfortunately, these policies have the unintended consequences that restrict and limit access to medications to manage symptoms for those most in need. Today we will be hearing from Dr. Robert Twillman and David Woodmansey. Dr. Robert Twillman is the Director of Policy and Advocacy at the American Academy of Pain Management. As a clinical psychologist, Dr. Twillman worked as a clinician in academic medical centers for 20 years prior to joining the American Academy of Pain Management. He has extensive experience in the treatment of chronic pain. In addition to his work at the Academy, Dr. Twillman oversees the development and operation of the State Pain Policy Advocacy Network, which seeks to improve pain care policies in the states. He also makes time to testify at federal advisory committees and congressional briefings, as well as at the state level. Dr. Twillman remains present and engaged in both traditional and social media. He has been quoted in nearly 20 articles in the past 2 years regarding pain care issues, is highly active on Twitter, and has authored numerous blog posts. Dr. Twillman is also a contributor to the upcoming documentary called Pain Matters, which is airing this Saturday at 8 a.m. on the Discovery Channel. So I recommend that you set your DVRs. Pain Matters explores the realities of chronic pain through the eyes of individuals who live with it, as well as the perspective from leading national experts in pain management, such as Dr. Twillman. Our second speaker today is David Woodmansey. Mr. Woodmansey is the Associate Director of Access to Care for the American Cancer Society Cancer Action Network. Mr. Woodmansey has extensive experience advocating for the American Cancer Society at the state level in Connecticut on issues ranging from stopping insurers from utilizing drive-through mastectomies where women were discharged the day of surgery, to advocating for comprehensive tobacco control, including clean indoor air policies. In 2004, Mr. Woodmansey expanded his national policy portfolio and began leading state issues regarding clinical trials, pain and palliative care, drug access issues, and private insurance coverage for cancer screenings. In 2010, Mr. Woodmansey was appointed as the American Cancer Society Cancer Action Network National Lead for all access issues in the state, including the Affordable Care Act implementation, Medicaid, and private insurance. Mr. Woodmansey has testified on behalf of the American Cancer Society and American Cancer Society Cancer Action Network in over 20 states and has met with staff volunteers, legislators in 49 states, missing only Alaska. Over his years of service to the Washington, D.C. office, Mr. Woodmansey is a resident of Connecticut and graduate of St. Bonaventure University in Olean, New York. Now please give your attention to our first speaker, Dr. Bob Twillman.
Thank you, Kristen. What I'm going to talk about is some of the issues that we've seen at the federal level, and David will follow up by talking a little bit about some of the issues that we're seeing at the state level. Both of those types of pain management policy can have significant unintended consequences for access to appropriate pain care. Next slide, please. These are some of the major themes, what we're hearing people say, particularly those who are in the policy-making arena. Many people are saying that there's an epidemic of prescription drug abuse and related deaths. They believe that overprescribing is causing this epidemic, and therefore the solution is to reduce prescribing. Rather indiscriminately is the way it's being put out there. Pressure is being exerted throughout the pharmaceutical distribution chain to achieve reduced prescribing and dispensing. We're seeing this go on at the wholesale level as well as at the retail level. And the impact on patients with pain is noted to be a concern, but oftentimes it's very much a secondary concern to controlling prescription drug abuse problems. A second major theme is that the federal government needs to increase its regulation of opioid analgesics as a way to, again, reduce the perceived overprescribing of these medications. There was a citizen petition earlier this year asking to change the label on opioid medications. That petition was partially denied and partially accepted, and in just a little bit I'll show you the particular language there. The FDA is recommending a rescheduling of hydrocodone products to be more restrictive, make it more difficult to get those medications, and again we'll delve into that in a little bit of detail. And there's been increased pressure to make participation in the risk evaluation and mitigation strategies for extended release and long-acting opioids mandatory rather than voluntary. Next slide. The third major theme that we're hearing is that abuse-deterrent opioid formulations are good things, that they prevent people from overdosing in particular and may prevent some people from abusing in the beginning. And so because they're good things, everyone should use them. We do believe these are an incremental step in the right direction, and more of them need to be available, but we have to balance concerns about the cost of these new medications with the need to protect patients, their friends, families, and society as a whole. We don't believe that everyone needs them. So that's another issue that I plan to touch on. Next slide. So we have two public health crises in this country that we're trying to balance the responses to. According to statistics from the Substance Abuse and Mental Health Services Administration, about 12.5 million Americans aged 12 years and older engaged in non-medical use of opioid pain relievers in 2012. That number has actually been remarkably stable since they first began asking about it in 2002. So for the last decade, this has been the number that they've been finding. It's estimated that prescription drug abuse of all kinds costs the economy about $70 billion per year in healthcare costs, perhaps as much as $120 billion per year if you include associated costs as well. On the other hand, we have the public health crisis of chronic pain. Kristen already showed you the numbers that say we have about 100 million American adults who have chronic pain. The IOM also estimates that chronic pain costs our economy between $560 and $635 billion per year, something I think we need to run right up to Capitol Hill with and see if we can't solve our budget problems by getting rid of chronic pain. Chronic pain is more common and more costly than cancer, diabetes, and heart disease combined. So it is really a major public health issue. And where we're left is trying to address both of these at the same time in ways that do more good than harm. Next slide. Along with prescription drug abuse comes a number of people who die of overdoses related to that abuse. The Centers for Disease Control and Prevention report that in 2010, about 16,600 Americans died of overdoses that involve prescription drugs. Now, it should be noted that those numbers are a little squishy, perhaps a little bit unreliable, because they rely on what's on death certificates. And what goes on death certificates is itself a little unreliable. The people who fill out death certificates may be elected county coroners who have no extensive medical training at all. And oftentimes information goes on death certificates that's incomplete, which makes it difficult to determine exactly what the cause of death or the sequence of events is. But nonetheless, these 16,600 deaths typically get painted in the media as prescription painkiller overdose deaths. It's the prescription pain relievers that get blamed for these people dying. However, the CDC also has research that indicates that about 75 to 80% of people who die of overdoses involving prescription drugs actually used multiple drugs, and those numbers do not include alcohol. They also note that as many as 55 to 60% of people dying of these overdoses did not have a prescription for the drugs involved. They essentially were using someone else's prescription drugs. Next slide. The CDC also likes to show this graph that you see on the left side of this slide. Just a couple of lines to point out here. The dotted line that's on the top of the graph is sales of opioid pain relievers from 1999 through 2010. The middle line, the solid line, is deaths of overdoses involving prescription opioids. And the bottom line is admissions to substance abuse treatment programs for primary abuse of opioid pain relievers. So the CDC notes that there's an apparent correlation between opioid sales and overdose deaths, that those two top lines are essentially parallel to each other. They suggest that that means increasing sales is causing an increase in deaths, and therefore, the way to reduce deaths is to reduce prescribing. We think that's an oversimplistic view. It's a very attractive view to policymakers because with one simple solution, a solution that would drive down prescribing, however that's done, you have potential to impact the number of people dying. But the unfortunate part is that driving down prescribing is not only going to affect those who are misusing the drugs, it's also going to affect the people who are using those medications appropriately. Those are the unintended consequences that we're seeing. And H.L. Mencken perhaps said it best when he said, for every complex problem, there's a solution that is neat, simple, and wrong. The problem of prescription drug abuse is a very complex problem, and I'm afraid it's going to take a very complex solution to address it appropriately. Next slide. Some of the initiatives that are underway at the national level to address prescription drug abuse, the ONDCP, the Drug Czar's office, puts out a national drug control strategy that's updated every year. The Association of State and Territorial Health Officers has an ongoing presidential challenge. It was just started about 3 months ago, actually, to address prescription drug abuse. And the National Governors Association has had a state policy academy in which they did projects in 7 states, again, attempting to address this. The stated goal for both ONDCP and for ASTO is to reduce overdose deaths by 15% by 2015. So 15 by 15 is their slogan. The nice thing about these initiatives is that unlike a lot of the things that we see going on in the legislative and regulatory arenas, these initiatives are balanced in terms of their recognition of the need to control prescription drug abuse, but also provide for the needs of people with pain. And they've been very good about involving some of us from the pain community in designing their intervention plans so that we try to do that. The other thing that's interesting about these plans is they all also address both the supply and demand sides of the drug abuse equation. Most of what's done for drug control in this country really focuses on the supply of drugs, such as what's being prescribed. We feel it's really important also to address demand, to address the problem of addiction and to treat that appropriately so that people aren't out looking for medications to misuse. Next slide. With respect to the opioid label changes that I mentioned earlier, there was a citizen petition from a group called Physicians for Responsible Opioid Prescribing that requested a change in the label for opioids. What the old label said, the label that existed at the time of this petition, was that opioid analgesics are indicated for the treatment of moderate to severe pain when a continuous, around-the-clock analgesic is needed for an extended period of time. Now, the portion of that label that comes before the brackets is for immediate release, short-acting types of pain relievers. When you add the brackets, that's referring to extended release and long-acting opioids. So the primary thing here is that it has to be for treatment of moderate to severe pain. The request that came from PROP had three components to it. First, to strike the term moderate from the indication when it's referring to non-cancer pain. Second, to add a maximum daily dose equivalent to 100 milligrams of morphine for non-cancer pain. And third, to add a maximum duration of 90 days for continuous daily use for non-cancer pain. So again, notice all these requests are for non-cancer pain as opposed to pain related to cancer. Next slide, please. We, along with our partners at the American Cancer Society, the American Academy of Hospice and Palliative Medicine, and a number of other groups, argued that the evidence supporting these changes was really inadequate. We also argued that making a distinction between cancer pain and non-cancer pain would be erroneous. It would be precedential. There is no precedent to do this so far with respect to federal regulation of medications. It would be a distinction without a difference, because we believe that it's really the proximal etiology of the pain that matters, not the presence or absence of cancer. So it's, for instance, a compression fracture that could be caused by cancer but also could be caused by osteoporosis. We don't feel that those things should be treated differently. Secondly, how do we define cancer pain? Does it include pain that's caused by cancer treatment? Traditionally, or at least when I learned about cancer pain 20 years ago, that was the case, but increasingly I hear people talk about cancer pain not as being caused by cancer treatment, but being caused by the cancer itself. What about long-term survivors with pain that resulted from their treatment? For how long would we call that cancer pain? After a certain period of time, does that become non-cancer pain and then subject to these kinds of regulations? That's not clear, but it's certainly a risk, especially given that for many insurance, what we see is that they're willing to provide whatever treatment is needed for pain related to cancer, but not so much for non-cancer pain. And finally, we also pointed out that the term non-cancer pain covers disparate pain conditions, some of which respond well to opioids and some of which don't. Again, that compression fracture that I talked about earlier resulting from osteoporosis would be included in non-cancer pain, but so would fibromyalgia. Fibromyalgia responds poorly to opioids. Compression fractures respond well. So to lump those things together would be inappropriate as well. Next slide. The FDA issued a decision on this in September. The new label will state, with respect to extended release and long-acting opioids only, they did not change the label for short-acting opioids, but the new label will say that these extended release and long-acting opioids are indicated for the management of pain severe enough to require daily, around-the-clock, long-term opioid treatment, and for which alternative treatment options are inadequate. We like the first half of that because it really focuses on what's really important, the patient's ability to function. The second part is a little concerning, the part that says for which alternative treatment options are inadequate. Our concern is that that could lead to the increased use of step therapy, as it requires people to try other treatment options before the opioids are allowed to be used. So that's something we're going to have to keep our eye on as things develop. requiring some post-marketing as a result of this label change. And they've also added a boxed warning that maternal use during pregnancy can result in a neonatal opioid withdrawal syndrome, which we're seeing increasingly as well. Next slide. Another issue that's going on at the federal level is hydrocodone rescheduling. The Drug Enforcement Administration requested that FDA evaluate whether hydrocodone-containing combination products such as Vicodin, Lortab, Norco, and others, they requested to evaluate whether that should be rescheduled into Schedule 2. So under the Controlled Substances Act, controlled substances are classified into one of 5 schedules. The 2 that are relevant for this discussion are Schedule 2 and Schedule 3. Schedule 2 medications are those that are deemed to have a legitimate medical use, but have the highest potential for abuse and addiction as a result of using them. Schedule 3 medications also are noted to have a legitimate medical use, but they're judged to be a little less addictive, have a little less addictive potential than Schedule 2 medications. The major difference between Schedule 2 and Schedule 3 is that in Schedule 2, you cannot call in prescriptions for the medications. You also cannot write for refills on the medications. So in essence, what has to happen is that for each time the patient runs out of medication or needs an additional supply, a new written prescription has to be generated. In Schedule 3, those prescriptions can be called into the pharmacy, and they can give refills up to 5 refills on a given prescription. So effectively, given that insurance typically only pays for a month's supply at a time, we're really talking about a 6-month supply as opposed to 1-month supply under Schedule 2. There's also greater security required throughout the pharmaceutical distribution chain for Schedule 2 products compared to Schedule 3 products. In retail pharmacies, Schedule 2s have to be kept inside a locked vault. Schedule 3 medications do not. So those are some of the implications of what would happen here. This request was first made in 2004 and rejected by FDA in 2008. The DEA then repeated its request in 2009, and that's the request that FDA is responding to now finally in 2013. Next slide. So the FDA convened an advisory meeting in January of this year. The advisory committee voted 19-10 to recommend rescheduling. But as they did, several of the panel members in their comments expressed some concerns. They expressed some skepticism that this would actively work to reduce hydrocodone abuse. One of the reasons for that is that there are some data out there suggesting that depending on which pieces of the data you look at, oxycodone, which is already in Schedule 2, may in fact be abused more frequently than hydrocodone products, which are in Schedule 3. There was some fear expressed by panel members that this would lead to an increased abuse of heroin, and in fact that's one of the things that we've been seeing over the past couple of years. As there's been a crackdown on prescribing of prescription drugs, what we're seeing is an increased use of heroin and concerns about that cropping up again. And many of the panel members also expressed a desire for a third option because in essence all they were asked to do was to vote yes, reschedule, or no, don't reschedule. Many of them expressed the notion that they wished there was a third option that was somewhere in between that might give greater control but at the same time not restrict access because they were mindful that doing this could restrict access for patients. In October of this year, the FDA announced that it was going to recommend rescheduling. There are 2 more steps for this to go through. That recommendation now has to be approved by Secretary Sebelius and forwarded on to the DEA. When it gets to the DEA, they must go through a rulemaking process in order to reschedule the medication. But given that they've asked for this review, we suspect that it's very likely that that will happen if this does get to FDA, or excuse me, get to DEA. Next slide. We're really concerned about some of the unintended consequences of this. Some providers have policies against prescribing Schedule 2 medications. These are typically just practice policies within their own medical practices. It's not that they're not allowed to by law or not that there's any prohibition against doing that, but many of them have decided that that's where they're going to draw the line. And so for those providers, what we may see is instead of using hydrocodone products, which are very frequently used, in fact, the most prescribed medication in America, Many of them will increasingly rely on codeine and tramadol products, which have much higher adverse event rates and have the potential to actually be ineffective for a certain portion of the population that doesn't have the appropriate enzymes to metabolize those drugs. Some mid-level providers are not allowed by state law to prescribe Schedule II medications. For instance, nurse practitioners in Texas are not allowed to prescribe Schedule II products. So in all of those states, the laws are going to need to be changed to allow this prescribing to happen. And given that Texas's legislature only meets an odd number of years, they won't get to that until 2015, unless they have a special session. We are concerned that patients will need to be seen more frequently by providers as a result of this. In 2011, there were 26 million refills for hydrocodone products in this country. And now we're somehow going to have to account for those with written prescriptions instead of the automatic refills. How those 26 million written prescriptions are going to be generated is anyone's guess. How many of them will require an actual office visit as opposed to patients just stopping by the office to pick up a prescription at the front desk is anyone's guess. But if all of them required office visits, we certainly are going to strain the capacity of our healthcare system, which is already strained. And the potential cost of the healthcare system could easily top $500 million a year and could approach $1 billion a year, depending on how many of these generate actual office visits. And certainly, this is major potential to disrupt patients' and caregivers' lives, to reduce productivity, to reduce quality of life, as people are having to run to the doctor's office every month as opposed to every 3 months or every 6 months. So we're very concerned about some of these unintended consequences. And again, this is something we're going to be monitoring in hopes that if we see problems show up, we'll be able to find a solution to them. Next slide. Finally, the other topic I wanted to talk about a little bit is abuse deterrent formulations. The FDA has been developing some guidance for these products, and we think they represent an incremental step. So the issue with these medications is that some of the long-acting opioid products, particularly the original OxyContin product, when it came on the market, we discovered that some people who were misusing the product were doing so by crushing it and then snorting the powder up their nose or injecting it. And that is a really dangerous practice because, in essence, what it does is gives you a dose of medication that's intended to be distributed over 12 hours. You get it all immediately. And people were dying of overdoses of that. It became a very popular way of abusing the medication. So what the pharmaceutical companies have been doing now is to develop medications that are no longer able to be crushed, or when they crush, they turn into a form that can't be snorted or can't be injected, or they include other products that, if they're crushed, would inactivate the opioid portion of the medication. So those are some of the ways in which they've developed these abuse deterrent formulations to keep people from changing the form of the medication as a way to abuse it. I think we've skipped ahead a slide or two. Good. One of the things that we will be seeing over the next year or so is some legislation at the state level to ensure that if a provider writes a prescription for one of these abuse deterrent formulations, when the patient takes that prescription to the pharmacy, it doesn't automatically get substituted for a non-abuse deterrent formulation. Our belief is that if a provider is writing for that specific form of the medication, that they're doing so because they think that the patient's at risk, or someone in the patient's family or social area is at risk of misusing that medication. So we feel that if that's what's ordered, that ought to be what's given to the patient. However, we're also very concerned about the financial consequences of this. These products, of course, are new, branded products, and so therefore are more expensive than the older generic products that don't have non-abuse deterrent formulations, which is why there's a risk of them being substituted at the pharmacies, because it would save the payers a lot of money. So we don't believe that patients who don't need an abuse deterrent formulation should be forced to pay that extra cost. We need to recognize that not every patient needs to use an abuse deterrent formulation. In fact, it's a small minority of all patients who misuse the drug in that way. So the majority of patients probably don't need an abuse deterrent formulation. So forcing them to pay extra as a result of someone else's actions we feel is inappropriate and would constitute a significant unnecessary increased costs of health care. So that's something we'll also be advocating for in that state legislation when that appears. Next slide.
One moment, Bob.
Okay, I thought that was my last slide. So those are some of the things that are going on at the federal level. There are a number of other issues that are more minor and less concerning, but these we feel have some very significant potential to create barriers to access for people with cancer who have pain and need to have that treated. With that, I think it's time for me to turn it over to David to talk a little bit about what's going on at the state level.
Thanks, Bob. I'm going to talk for a few minutes about some of the issues that we have seen at the state level and some of the things we are anticipating we might see at the state level in the coming months in the next year or two. First thing that I wanted to talk about is obviously at every state level we have laws and specific laws and regulations that deal with pain relief and medications that allow for that. Bob is going to talk, when Bob comes back a little bit later, he's going to talk about a report card that's done by the Pain and Policy Study Group out of the University of Wisconsin, and that is really what we use as our frame, the groundwork that tells us where we need to spend special attention, whether it be laws or regulations at the state level. And it's really a nice guide that simplifies what for many people at the state level is a very complex and intricate problem. Using this report card really simplifies it and tells you exactly where you need to put your time and your energies, or where you should be putting your time and your energies. And I will take just one more second on in talking about laws at the state level to specifically mention something that Bob just talked about on his very last slide, and that is substitution. When a prescription is written by a doc for a patient, pharmacists, in some states there have been attempts to allow pharmacists to substitute without doctor-patient notification. And not just in the pain world, but in other aspects of drug use and prescribing, we as the American Cancer Society Cancer Action Network speak out very loudly and very forcefully as possible about that. If this practice is going to be allowed, the doctor absolutely needs to know. The patient should know too, but absolutely the doctor at the very least needs to know. And we speak up on behalf of that very often at the state level when there are considerations being given to allowing pharmacists to switch out a prescription, even if it's a very, very similar prescription or drug. The physician has to be notified from our perspective before that's allowed to happen. Another barrier at the state level is there is still uncertainty among some providers in certain states. There are model guidelines that many of you have heard us talk about for years. Federation of State Medical Boards issued model guidelines, and they actually updated them not too long ago. It's a nice way for the doctors, the nurses, the pharmacists on a state level to know what is expected of them, what is within the law, what is outside of normal practice. And if those entities, those three entities in particular, pass the model guidelines, it really goes a long way to, I shouldn't say pass because that makes it sound like it's a law, adopt those model guidelines, because you're not passing a law, you're adopting model guidelines from a federal, that have already been adopted at a federal level. It allows those providers to then know what the rules of engagement are that they're expected to adhere to in prescribing opioids. And there is still some uncertainty in certain states because, even in states where these have been adopted, they're not sometimes publicized, or the awareness is not there among providers that these have been adopted. The next point I wanted to make is media. I don't think I need to go in a whole lot of detail about this. The media tends to, on this issue, come from a certain angle. A lot of times, as Bob alluded to, a high percentage of folks that unfortunately die of overdoses often are mixing drugs. Often alcohol is involved, though that is not normally documented. And very often the people that die from these overdoses are not even the ones that were prescribed the drugs. They didn't even hold a prescription for the drugs. Now, it's very, very difficult to talk about that in a hearing room or in a venue where you have grieving families of folks that are young adults or not even yet adults that have been impacted in the most adverse way by this. It's very, very difficult. We understand that, but at the same time, we have to try to balance the story as it's being told, and sometimes it's not easy, sometimes it's impossible. But wherever it is possible, we have to try to do that. And then the last thing I wanted to bring up is pharmacies. Bob mentioned the wholesale level, and he mentioned the retail level. Unfortunately, we are seeing Florida stands out, but Florida is not the only case. But we have seen certain situations in certain states where pharmacy chains decide that they're not going to carry certain drugs anymore. And in the worst cases, it's where patients have gone to get their drugs for many years and have had absolutely no issues, obtaining their drugs through those channels. And with little or no warning, all of a sudden they show up, expecting to get, the same drug that they've always been able to get, and they're told that, the drug is no longer carried in that pharmacy or in that chain. So it really creates a problem, and, we've been very active in trying to identify where this is happening and, again, fire off letters or try to get meetings to, once again, talk about the need for balance in policies and how important that is. And you're going to, unfortunately, you're going to hear me say balance a lot, but that is the key for us in regard to this issue. So, the pharmacies certainly are one of the frontline areas that are most concerning to us, and something that we try to be as impactful as possible in telling the patient perspective, the patient story to these pharmacies and to these chains. The next slide, please, deals with, I didn't put a whole lot of detail underneath this because I just want to be very, very clear, and Bob was talking about this also. Legislators and other groups try to drive a wedge between us and other types of pain on the state level, and even at the federal level, but I'm just talking on the state level because that's where my expertise is, and we never can allow this to happen. Opioid receptors don't know cancer pain from non-cancer pain. It's just pain. And unfortunately, cancer patients can become dependent on these drugs and sometimes addicted to them too. So, the cancer patient should not be outside the protective cone that we try to establish for people who are using these drugs, these opioids. So again, I just want to be clear. It happens a lot, so I just wanted to make sure we made the point from a ACS CAM perspective during this call that you'll probably see people try to do it, but we certainly do not advocate going there, and we think that the best way to be strong on a state level and a federal level is to really do the best thing possible to stick together and try to get people to understand that pain is pain. It doesn't matter what's causing it. It's just what matters is people have pain, patients have pain that needs to be dealt with. So next slide, please. Again, we don't stick our head in the sand. We applaud law enforcement. We know drugs are diverted and abused, and we encourage them to go and find those and punish those. I've made the case a couple times testifying in different states about this issue, especially when it's evident that it might be a committee that's a little more hostile to the position we're taking, that banks in this country get robbed every single day. You never hear people say, let's close the banks. What you hear people expect is that law enforcement is going to, A, prevent people from robbing banks, and when, unfortunately, banks do get robbed on occasion, law enforcement deals with it. But you never close the banks to the millions of people who are law-abiding that use the banks legally every day. So, there's a little bit of an analogy that can be made in what we're talking about here. But again, while we certainly want to help prevent misuse and abuse, there's a couple avenues that are being pursued that we don't think are 100% looking at the entirety of the problem. A lot of these monitoring programs and what Bob was just talking about, the FDA and DEA, it's all in the back of the providers for the most part. Yes, there is some patient hardship if there has been some system hardship if people have to physically go back every month. But a lot of the focus heretofore has been on providers. And, there needs to be an increased education, increased public awareness of, again, the balance that needs to happen and some of the public protections and provisions that should be and could be put in place to make sure that people aren't so apt to abuse these medications, especially those that don't even have prescriptions for the medications. And then the last thing I will bring up is, in some cases, the best remedy may not even be drugs. In many cases, it is. In many cases, drugs are part of the solution. But we as an organization, ACS and ACS CAN, have embarked on a very ambitious quality of life palliative care initiative. And one of the main tenets of that is that that we should not be siloing pain and other aspects that go into effective quality of life enhancement. That we should be raising everything equally, and that other components, psychosocial, dealing with depression, that there are many other things that go into successfully treating the whole patient, and pain management is but one of those. And there are other things that can certainly better a patient's quality of life and limit the pain that patients may be experiencing. Next slide.
Yeah. So now we are going to move into an overview of some of the resources that exist to help you advocate. And we are going to unmute your line, Bob, so that you can also talk about these tools. The first one that we are going to speak about is ACS CAN's How Do You Measure Up report.
Okay. Yeah, this is a report that we've now published for 10 years as of this past August. And what it does is it measures our priority issues for every state in the country. And whether it's in tobacco, prevention, access to care, things like that. We measure all of our priority issues. And for many years, we have been measuring pain. And we're a little different than what the report card Bob's going to talk about, in that we don't have 16 criteria, but we factor in not only the policy environment of state, but what's actually happening on the ground. We use a little different criteria to try to focus in on that. And again, we're not real specific. We go red, yellow, green, which leaves a lot of leeway and a lot of gray area. But it's a way, and we release this every year at NCSL, which is National Conference of State Legislators, and it's become wildly popular. I mean, the first day of the event, these legislators were running to our booth. I never thought I'd see legislators run to our booth for a document that we produce, but they do, and they open the document, they look at where their states are, especially in regard to their neighbors, and they want to know on the spot, and we're working the booth, and they want to know, why is my state red? Why is my state yellow in this topic, this issue? And it really allows us to have a dialogue, but it also allows you at your own state level, advocates out there, and folks that care about these issues, to get a copy. It's available online. You can see it on the screen there. It's available online. You can go and you can check out your state in regard to pain. We also this year, for the first time, have a palliative care section that you can also see, and you can see some of the other priority issues. But for today's conversation, we'll focus on pain. So if you're mindful of where your state is in our measurement system, I would encourage you to go to our website and check it out. And there's a narrative with the section too that is helpful in understanding where we're coming from in regard to some of these issues on a state level.
Thanks, Dave. And now I'm unmuting Bob, and this is just a reminder to please submit any questions that you have using the question function on your screen, and we will have about 5 minutes of question and answer at the end of the webinar. And questions that are not answered, we will be emailing out the answers following the webinar on Monday. So Bob, if you can go ahead and speak about the SPAN toolkit.
Sure. So one of the other resources that we have available that really is focused on state-level policy is our organization we're calling the State Pain Policy Advocacy Network, or SPAN. The SPAN website, for which the URL is at the bottom of this slide, does a number of things. It really gives you a lot of tools to focus on state-level issues that are related to pain management. And believe me, there are a lot of them. This year we've tracked about 900 pieces of legislation that are somehow related to pain management, and well over 500 pieces of regulation that are related to pain management. So what we do on this website is to track some of those things that are proposed, organized both by state, so you can click on your state and see what's active out there, as well as by issues. So for instance, you could click on our link that says prior authorization, and you get all the bills across the country that are dealing with prior authorization issues. We also have some explanatory information for the most important issues, about a series of, 10 or 12 of those issues. We've got some explanatory information, some position statements that we posted, model legislation, blog posts, whatever we have that we've generated related to that particular issue, and links to those things so that you can use them and help yourselves to address these particular issues. In 2014, one of the things we'll be doing is adding to our resource page on this website with a series of policy briefs about some of the key issues. We're really intending these to be one-page policy issues or policy issue briefs that you could use to take to a legislator or a regulator to say, here's the basics on this issue, and this is what we want you to do. So I'd encourage you to go to the website, span.aapainmanaged.org, and take a look around. Let us know if you're interested in being involved. We have over 120 organizations that are somehow involved in this network, and we take individuals as well who are interested in being advocates for good pain policy. So we'd love to have you involved, and there's ways to do that through the website. Dave has talked a little bit about this report card that comes from the University of Wisconsin's Pain and Policy Studies group. This is something that's gone through a number of iterations over the years. The most recent one was issued based on calendar year 2012 legislation, bills, laws, and regulations across the states. What you can do is to look in here at your state and find what are the pieces of legislation that are related to, or excuse me, not legislation, laws that are related to pain management. What they've done is develop a scoring system that looks at things in the law that may prohibit good pain management, some things that may encourage good pain management, and based on how many of each of those appear in the state, they're able to give a letter grade just like you'd get in school. That's a great tool to be able to give to a legislator to say, hey, look, we only have a B- and we need to have an A, so let's figure out what we have to do. This guide will tell you exactly what you have to do to accomplish that A grade. Next slide.
And Bob, just if I can give a 30-second commercial here, whenever we talk about this document that comes from the University of Wisconsin, we like to make sure that we thank Livestrong because they partner with us in providing the funding for this with ACS and ACS CAN in providing the funding for this document. And as you mentioned, the last one with information from 2012 we just released in May, and it's been very well received. So just we'd like to make sure that we thank our partner whenever we talk about that document.
Absolutely. Thank you, Dave. So these are some of the things that we're encouraging you to do to help take action. We need to advocate against restrictive policies and for increased access to pain management therapies of all types, not just medications, but as Dave mentioned earlier, there are a lot of other things that people do that really help pain, and we need to advocate for increased access to those things. Groups, particularly in the states that are drafting prescribing dispensing guidelines, need to hear about the consequences of access. Several years ago, there was a push in the state of Washington to do this, and now we finally got some published research that shows that, yes, in fact, it did create access problems, like all of us said it would. So people need to hear about that. We need to advocate for adequate coverage of non-pharmacologic services to treat pain, as I just mentioned. We need to be sure that efforts to eliminate pill mills, those that are out there just willy-nilly prescribing massive doses of medication to people who don't actually have pain, the efforts to eliminate those shouldn't unduly restrict the legitimate providers who we need more of to treat all of the pain that we have for the 100 million people in this country with chronic pain as well as others. So with that, I'll turn it over to Kristen. Looks like she's got a call for stories.
Yep, so we are interested in hearing any stories that you may have either from a loved one, a patient, a provider, a pharmacist where there have been issues in accessing medication for people with cancer. So please send me any stories that you have, or if you're interested in setting up a phone call, just shoot me an email. And we're now going to move into our question and answer portion of the webinar. We have about 5 or 6 minutes for questions, and so please submit your questions using the question function on your screen. 2 have come in so far. The first one, how can I get involved in helping increase awareness of pain education and advocate on the state and federal level? We just covered some of those topics, but this came specifically from a chronic pain patient who's now suffering due to the wedge between the cancer and non-cancer pain issue. So Bob or Dave?
Well, if you contact us with the SPAN initiative, one of the things that we will do is not only involve you with SPAN, but we'll also put you in contact with the appropriate patient advocacy groups. There are a number of groups that really are based on patients or people with pain advocating for themselves and for others with pain, and we'll put you in touch with those groups as well so that you can find more like-minded folks to work with too.
Absolutely, and you know, we have government relations staff on the ground in all 50 states. We're very fortunate in that regard. And you know, anyone on this call, not just the person that's asking the question, if you want to know who your local state person is, just send me an email. Just put a dot between my first and last name at cancer.org, and you got me. That's one. What we try to do with stories with patients such as the one that just asked that question is make sure that we provide an opportunity for them to be heard in front of legislatures when issues like this come up. So by all means, SPAN, you know, we're locked at the hip with them in many states, but in some states where it's, you know, we have a presence and others may not, we're more than happy to work with any and all, and you know, we're trying to build partnerships in all states right now, and that's the way to be effective with this kind of work, is to have as many individuals and organizations as possible all pulling in the same direction.
Thanks, Dave. And when we send out the slides and the link to the recording of the webinar, we'll also have your contact information and Bob so that people can reach out and ask questions. The next question, how many of the state cancer coalitions have an objective or goal dealing with this topic? I don't know if you know the answer to that, Dave.
I don't know off the top of my head, but I do know our state government relations staff know that this is a priority issue for us. And in many states, the Comp Cancer Coalition advocacy or policy chair is the ACS-CAN government relations director of that state. So, and that's in about 80% of the states. So, you know, there's a pretty healthy presence, at least in the advocacy or in policy committee venue on those statewide Comp Cancer Coalitions. But it's not that way in all states. So I would encourage you, if you're in a state that doesn't seem to have this as a priority for its Comp Cancer Coalition, reach out to Bob or myself or Kristen, and we can help facilitate making that happen.
Thank you. Regarding the abuse deterrent formulations, do you propose guidance to doctors to make this decision? Is there any thought in how that will work out? Bob?
That'd be Bob.
Yes, you know, increasingly what we're talking to doctors about is when they're making a prescribing decision, they need to evaluate the patient not only for what's going on with them with respect to pain, but they also need to be evaluating the risk that these might be patients who would misuse the medications. And not only the patients, but also people in their their social circles. So if they've got, for instance, a teenager at home who might get into the supply of medication and take it to a party, or if they've got somebody coming into the house on a regular basis who might access it, that's another risk. So what we're telling prescribers to do these days is they really have to do that evaluation along with the pain evaluation. And based on the level of assessed risk, they need to decide whether or not the abuse deterrent formulations are appropriate or necessary for that particular patient.
Thank you. And it looks like those were all of our questions. So I'd like to thank today's speakers for sharing their expertise and for the participants for your thoughtful questions and your time today. This webinar is C-Change's first step to work to reduce barriers and increase access to appropriate pain management therapies, but we really need your help in doing so. We will be holding additional webinars in 2014 that will take a deeper dive into some of these issues presented today, as well as the tools and resources that exist to help in your advocacy efforts. The evaluation that you will receive after this webinar will help us determine which topics we will be focusing on in 2014. So please be sure to complete your evaluation. As I mentioned earlier, we would also like your help in gathering any personal stories that you have so we can help in our advocacy efforts. This concludes today's webinar. If you have any remaining questions, please send them to me at kcoxsantiago@cchangetogether.org, and I will work with today's presenters to answer them. I would like to once again thank the presenters for their insights and to all of you for taking part in this webinar. A recording of the webinar and the slides with contact information as well will be emailed out on Wednesday and will also be on our website. Thank you.